Welcome students. This is Dr.Diptee Wariko, Department of Physiotherapy, Dolphin Institute of Biomedical and Natural Sciences. Continuing with our lecture on biomechanics of wrist and hand complex, today we will be dealing with the biomechanics of hand. So starting with the biomechanics of hand, we all know that the hand consists of 5 digits, 4 fingers and a thumb. Each finger has one carpometacarpal joint, one metacarpophalangeal joint, two interphalangeal joints, that is the proximal and distal ones, whereas our thumb has got one carpometacarpal joint, one metacarpal joint, and only one interphalangeal joint. Overall, there are 19 bones, the metacarpals and phalanges, 19 joints, distal to the carpals. So first joint what we will be starting are the carpometacarpal joints of fingers. The carpometacarpal joints of fingers are composed of articulations between the distal carpal row and the base of the second through fifth metacarpal joints. The distal carpal row also, of course, is part of the midcarpal joints. The proximal portion of the four metacarpals of fingers articulate with the distal carpals to form the second to the fifth carpometacarpal joint, the first being the thumb. The second metacarpal articulates primary with the trapezoid and secondary with the trapezium and capitate. The third metacarpal articulates with capitate and fourth metacarpal articulates with capitate and hamate. The last, that is the fifth metacarpal, that articulates with the hamate. Each of the metacarpals also articulate at its base with the contiguous metacarpal or metacarpals, with the exception of the second metacarpal which articulates at its base with the third but not the first metacarpal. All the fingers carpometacarpal joints are supported by strong transverse and weaker longitudinal ligaments, which are very important ligaments. The deep transverse metacarpal ligament covers the second to fourth metacarpal volarly and together the metacarpal heads, and this prevents excessive abduction, which contributes to carpometacarpal joint stability. Although the transverse metacarpal ligament contributes to carpometacarpal stability, it also is structurally the part of metacarpophalangeal joints. One attribute of the distal carpal that affects carpometacarpal joint and the hand functions but not the wrist is the volar concavity or the proximal transverse arch. Okay. The carpal arch persists even when the hand is fully opened and is created not only by the curved shape of the carpals but also by the ligaments that maintain this concavity. It is formed by trapezium, trapezoid, capitate and hamate, which is concave volarly. This concavity is maintained by transverse carpal and intercarpal ligaments. This forms carpal tunnel, which you will read in your further classes. And this there is median nerve and 9 extrinsic flexor tendons passing through this carpal tunnel. Here you could see the carpometacarpal joint. Here is the carpal tunnel in the first figure, beneath which the median nerve enters the hand. Now let us discuss about the carpometacarpal joint range of motion. The range of CMC motion of the second through fifth metacarpal is mostly readily at the metacarpal heads and shows increasing mobility from the radial to the ulnar side. The second through fourth carpometacarpal joints are plain synovial joints with 1 degree of freedom, that is, we will have the motion in flexion and extension. Although structured to permit flexion and extension, the second and the third carpometacarpal joint are essentially immobile and may be considered to have a 0 degree of freedom. The fourth carpometacarpal joint has some flexion extension. The fifth carpometacarpal joint is a saddle joint with 2 degrees of freedom, including flexion extension, and somewhat we can have abduction and adduction. The immobile second and third metacarpals provide a fixed and stable axis, but with the fourth and fifth metacarpals, and the very mobile first metacarpal, that is the thumb, which we'll see in the later classes, has a mobile movement. Now we come to the metacarpophalangeal joints of the fingers. Each of the 4 metacarpal joints of the fingers is composed of the convex metacarpal head proximally and the concave base of the first phalanx distally in all the 4 fingers. The metacarpophalangeal joint is a condyloid joint with 2 degrees of freedom. So we will have flexion extension and abduction and adduction. The large metacarpal head has 180 degrees of articulating surface in the sagittal plane, with the predominant portion lying volarly. This is approximately to 20 degrees of articular surface on the base of the phalanx. In the frontal plane, there is less articulator surface than in the sagittal plane, and the articulating surfaces are more congruent as compared to the other joints. This joint is surrounded by capsule that is generally considered to be lax in extension. Then we have collateral ligaments at the volarly located deep transverse metacarpal ligament. These ligaments enhance the joint stability. We also have volar plates, which are very important factors for flexor stability at the metacarpophalangeal joints of the fingers. The volar plates, or we call them as palmar plates, at each of the metacarpal joint is a unique structure that increases joint congruence in these areas. They are composed of fibrocartilage and is firmly attached to the base of proximal phalanx. These volar plates become membranous proximally to blend with volar capsule at your metacarpal heads. During we are doing, see, this volar plate can also be visualized as fibrocartilage impregnation, which are seen at the volar portion of the capsule, and they are superficial to the metacarpal head. Okay. During the MCP extension, these plates add up the amount of surface in contact with large metacarpal heads. So this is the basic thing of the volar plate. These fibrocartilage compositions also resist both tensile stresses and comprehensive forces, therefore playing a very vital role in the stability. Now, during the flexion, these volar plates glide proximally and prevent pinching of long flexor tendons at your metacarpophalangeal joints. They also blend with and are interconnected superficially by the superficial transverse metacarpal ligament. They also have the sagittal bands dorsal to the deep transverse metacarpal ligaments, which are very important bands to stabilize the volar plates at its position. Here you could see the volar plates. This is the volar plate presented on the anterior or the volar aspect of the metacarpophalangeal joint. Then are the collateral ligaments. The radial and the ulnar collateral ligaments of the metacarpophalangeal joint are composed mainly of the 2 parts. The collateral ligament proper, which is a cord-like structure, and the accessory collateral ligament. So these are the 2 parts. Tension in collateral ligament at full MCP joint flexion also helps in limiting the metacarpophalangeal abduction while in full flexion. This is also considered as the closed pack position of the joint. These collateral ligaments provide stability throughout the metacarpal joint range of motion. Now let us talk about the range of motion of the metacarpophalangeal joints. So the total range of motion available at the metacarpophalangeal joint varies with each finger. Flexion and extension increases radially to ulnarly, with the index finger having approximately 90 degrees of MP joint flexion and the little finger having approximately of 110 degrees. Hyperextension is fairly consistent between fingers, but it may vary from individual to individual. Also, it depends on the laxity of the ligaments around the joint. The range of passive hyperextension has been used as a measure of generalized body flexibility. The range of abduction adduction is maximal in MP joint extension. The index finger and the little finger have more frontal plane mobility than do the middle and ring finger. Passive rotation of the MP joints has been measured, which supports the contention that this mobility allows for adaptation of grasp for different sized objects. So we were discussing about the metacarpophalangeal joints. This is the metacarpophalangeal joints. We have already discussed about the carpometacarpal joints. Now we are moving to the interphalangeal joints. As we know, we have two interphalangeal joints in the fingers, the proximal and the distal interphalangeal joints. So each of the proximal and distal interphalangeal joints of the fingers is composed of head of the phalanx and the base of the distal phalanx. Each interphalangeal joint is a true synovial hinge joint with 1 degree of freedom, that is flexion and extension. It has got a joint capsule, a volar plate and two collateral ligaments around it. The base of each middle and distal phalanx has two shallow concave facets with a central ridge. The distal phalanx sits on the pulley-shaped head of the phalanx proximally to it. The joint structure is similar to that of what we have seen in the metacarpophalangeal joint in the proximal part of the previous lectures, but unlike the metacarpal joint, there is little posterior articulating surface at the PIP and DIP joints. Therefore, little hyperextension is available. We also have volar plates which help to reinforce each IP joint capsule, enhance stability and limits hyperextension. Similar to the MCP joint plates except number connection with deep transverse ligament. Then we have the collateral ligaments. The collateral ligaments are the cord-like ligaments. They are similar to the MCP joint. They provide stability to the joint, but injuries to the proximal interphalangeal joint, collateral ligaments are commonly seen in sports people. So now the total range of flexion extension available to the index finger is greater at PIP joint, that is 100 to 110 degrees, than it is at the DIP joint. The ranges for PIP and DIP flexion at each finger increases ulnarly, with the fifth DIP and PIP joints achieving 135 degrees and 90 degrees respectively. This pattern of increasing flexion extension range from radial to ulnar side of the hand is consistent at carpometacarpal, metacarpal and PIP joint. Students, you have to remember this. This is the important fact. Additional range to ulnar fingers favors the angulation of the fingers towards scaphoid and also assists the movement, that is opposition of the thumb. Okay. Then we come to the musculature, and first we will discuss about the extrinsic finger flexors. Muscles of the fingers and thumb have proximal attachments above the wrist. The muscles, also called as the motor components of the fingers and the thumb, which have the proximal attachments to the wrist, are also known as extrinsic muscles. And those muscles which have got attachment distal to the radiocarpal joint will be called as intrinsic muscles. Functionally, the muscles we are discussing now, the extrinsic muscles, are also divided into two parts. First are the flexors and another are the extensors. The intrinsic muscles are typically not referred to as flexors or extensors, as we will see here the extrinsic muscles. So we have the flexors, mainly the FDS muscle, which can produce more torque at MP joint than can produce the FDP muscle. So FDS flexes proximal IP joints and MCP joints. It produces more torque as compared to the flexor digitorum profundus. Superficialis produces more torque as compared to the profundus. It crosses few joints and superficial to the flexor digitorum profundus at your MCP joint. It has also got greater moment arm for MCP joint. This is about the FDS, flexor digitorum superficialis. Flexor digitorum profundus flexes metacarpophalangeal joint, interphalangeals both, distal interphalangeal as well as proximal interphalangeal more actively. Now, during finger flexion with wrist flexion, both the flexor digitorum superficialis and your profundus works together. At the proximal phalanx, when we talk about the proximal phalanx, FDP emerges through splits in FDS. When the FDS splits into two parts, through the camphorous chiasma, the FDP emerges and attaches to the FDS attaches to the base of middle phalanx. Both FDS and FDP are depending on wrist position. That is, length tension relationship of both the muscles will be depending on the wrist position. Counterbalancing the extensor torque at wrist, which is provided by extensor carpi radialis brevis or sometimes by extensor digitorum. Now, let us discuss about the mechanism of finger flexion. The optimal functions of both the flexors, that is superficialis and profundus, mainly depends on 2 points. First being the stabilization of the wrist musculature, how much wrist is stabilized and functioning, and second is the intact flexor gliding mechanism. Now, this flexor gliding mechanism consists 3 things. First, the flexor retinaculae, the bursae around the wrist, and the digital tendon sheath. Now, as the tendons of FDS and FDP muscles cross the wrist to enter the hand, they first pass beneath the proximal flexor retinaculum and through the tunnel, that is the transverse carpal ligament. Friction between the tendons themselves and friction of the tendons on overlying transverse carpal ligament are prevented by the bursas, that are the radial and the ulnar bursa. Now, all the 8 tendons of FDP, 4 of FDP and 4 of FDS are invested in a common bursa, which we call as ulnar bursa. The bursa is compartmentalized to prevent friction of tendons on other tendons. Now, the FPL muscle that accompanies the FDS and FDP muscles through the carpal tunnel is encased in its own bursa, that is the radial bursa. The radial and ulnar bursa contain a synovial-like fluid that minimizes the friction forces. That is very important. We need to know this. Now, the FDS and FDP tendons of each finger pass through fibroosseous tunnel, which comprises 5 transversely oriented annular pulleys and 3 obliquely oriented cruciate pulleys. So, we will be having 5 pulleys acting here on the flexor mechanism and 3 cruciate pulleys, 5 annular, 3 cruciate pulleys. So, what are these 5 annular pulleys? A1, A2, A3, A4 and A5. A1 pulley is at the head of the metacarpal. A2 is the volar midshaft of proximal phalanx. A3 is present at distal most part of the proximal phalanx. A4 centrally on the middle phalanx and A5 on the base of the distal phalanx. Here you could see A1, A2, A3, A4 and A5. The base of each pulley is longer than the roof superficially and roof has slightly concavity volarly. This prevents the pulleys from pinching each other at the extremes of the motions, that is the flexion. This also minimizes the pressure on the tendon when the tendon comes under tension. So this was about the annular pulleys. Next we come to the cruciate pulleys, the C pulleys, cruciate pulleys. So cruciate pulleys, we have three cruciate pulleys. The first cruciate pulley C1 is present between A2 and A3 pulley. The second cruciate pulley C2 is present between A3 and A4 pulley. The third cruciate pulley is present between A4 and A5. A4, A5 and C3 contain only FDP tendons and there are no flexor digitorum superficialis tendon passing through these pulleys. Thumb will have its own different pulley system. So function of these, what are the function of these annular pulleys? They keep the flexor tendons close to the bone. They allow only a minimum amount of bowstring and migration volarly from the joint axis, and they also enhance the tendon excursion. Now we come to the extrinsic finger extensors. So extrinsic finger extensors are mainly the extensor digitorum communis, extensor indicis proprius and extensor digiti minimi. These tendons pass from forearm beneath the extensor retinaculum that maintains proximity of the tendon to the joints. These also improve the excursion of the efficiency excursion and efficiency of the tendons. So the extrinsic finger extensors, they are very important tendons. So they emerge right and help in the function of the finger extensor. At approximately the MP joint, the EDC tendon of each finger merges with a broad aponeurosis known interchangeably as the extensor expansion. We also call it as dorsal hood or we also call it as that extensor hood. So do not get confused with this, students. The extensor indicis and extensor digitorum minimi tendon insert into the extensor digitorum communis tendon of the index finger and the little finger respectively, or just proximal to the extensor hood. These tendons are very important for the finger extension. Now this here you could see all the tendons, the extensor digitorum communis, proprius and extensor digiti minimi. Now these tendons are the only muscles capable of extending the metacarpophalangeal joints of the fingers. These muscles extend the MP joint via their connection to the extensor hood and sagittal bands that interconnect the volar plates and the extensor digitorum communis tendon or the extensor hood. Distal to the extensor hood, these tendons split into three bands. Now how they tendon? They cross the distal extensor hood, split into three parts. One is the central tendon which goes directly straight and inserts on the base of the middle phalanx. Then there are the two lateral bands which cross the middle phalanx and then rejoin to form a terminal tendon and then insert into the base of the distal phalanx. Here you could see this, they come the terminal, this is the central tendon, the bands, lateral bands, then they join to form a terminal tendon which inserts over the distal phalanx. Now we will discuss about the extensor mechanism. So the foundation of the extensor mechanism is formed by the tendons of the extensor digitorum communis, the extensor hood, the central tendon, the lateral bands and the terminal tendon. The first two components that we will add to the extensor mechanism are the passive components of the triangular ligament and the sagittal bands. Then
The lateral bands are interconnected dorsally by a triangular band of superficial fibers. Okay, we remember that these are known as the triangular ligament, or we also call them as dorsal retinacular ligament. The triangular ligament or the dorsal retinacular ligament, how does it help? It helps in stabilizing the bands on the dorsum of the finger. Then the sagittal bands connect to the volar surface of the hood, to the volar plates and transverse metacarpal ligament. These sagittal bands aid in stabilization not only to the volar plates but also of the hood at the metacarpal joint. They also prevent bowstring of the extensor mechanism during active metacarpophalangeal joint extension. These sagittal bands are also responsible for centralizing the EDC tendon over the metacarpophalangeal joint. So what will it help? It will help in preventing tendon subluxation. Okay, these are the important structures of your extensor tendon, this muscles. There are also dorsal introosseous, volar introosseous, lumbricals, which are active components of the extensor mechanism, which we will deal one by one. There is also one passive element of the extensor mechanism and very important, that is your oblique retinacular ligaments. Okay, the final passive element, with that is the oblique retinacular ligaments, they arise from both, they arise from the both sides of the proximal phalanx and from the sides of the annular and cruciate pulleys volarly. They continue distally as slender bands to insert on the lateral band distal to the PIP joint. Okay, so the oblique retinacular ligaments lie volar to the axis of the PIP joint and dorsal to the axis of DIP joints. So function of extensor mechanism can also be very much depending on the oblique retinacular ligament. Now the intrinsic finger musculature, which is very important and which plays a very important role in the hand mechanism. So isme the important functions what we will see is the dorsal and volar introosseous. The dorsal and volar introosseous, these introosseous arise between the metacarpals and are important part of the extensor mechanism. There are 4 dorsal introosseous functioning and 3 to 4 volar introosseous or palmar introosseous. The dorsal and volar introosseous are alike in their location and some of their actions also. But we characterize them by their ability to produce metacarpal phalangeal joint abduction and adduction. The dorsal introosseous do abduction and the palmar introosseous do adduction. The introosseous muscle fibers join extensor expansion in 2 locations. Some fibers attach proximally to the proximal phalanx and to the extensor hood. Some attach more distally to the lateral bands or to the central tendons. Okay, so the first dorsal introosseous has most consistent attachment. It attaches into bony base of the proximal phalanx and extensor hood. Second and third dorsal introosseous have both proximal and distal attachments. Fourth dorsal introosseous, not actually present sometimes, along with the abductor digiti minimi, plays a very important role. The 3 volar introosseous muscles have distal attachments only. Proximal introosseous have predominant effect on metacarpophalangeal joints only, but the distal introosseous will produce their predominant action at IP joints and some affect the metacarpophalangeal joints. All these introosseous pass dorsally to the transverse metacarpal ligament but volar to the axis of metacarpal phalangeal joint. So there is important function or the role of these introosseous muscles at metacarpophalangeal joint. They are very important. They have an important role. So let us discuss about the role of introosseous. When the MCP joint is in extension, so the movement arm of all the introosseous muscles for MP joint flexion is so small that a little flexion torque is produced. Okay, so in spite of their poor flexion torque, the interossei muscles appear to be important in helping to prevent clawing of the fingers because they balance passive extension in extrinsic extensors at MCP joint at rest. Interossei muscles are effective abductors and adductors, as I told you earlier. Proximal insertion of the muscles are more effective than the distal insertions. Already I told you this point also. So now let us see the role of interossei at the metacarpophalangeal joint flexion. So as the MCP joint flexes from extension, the tendons and action lines of the interossei muscle migrates volarly away from the MP joint's coronal axis. This increases the moment arm for metacarpophalangeal flexion. So we can say these increase the flexion torque at MCP joint as it approaches to full flexion. The volar migration of interossei is restricted by deep transverse metacarpal ligament. This prevents loss of active tension and serves as an anatomical pulley. When we talk about full metacarpophalangeal flexion or abduction adduction, this is restricted due to tight collateral ligaments, the shape of the condyles on the metacarpal heads, and the active insufficiency of fully shortened interossei muscles. Now let us discuss about the role of these interossei in interphalangeal joints extension. So, the ability of the interossei muscles to produce interphalangeal joint extension is influenced by their attachments. To create sufficient tension in the extensor mechanism to contribute effectively for the interphalangeal extension, the muscles must attach to the central tendon, or if not to the central tendon, to the lateral bands. All the interossei muscles have distal attachments except the two outside the abductors. Okay. So when the MP joint is extended, the action lines of the distal interossei are ineffective in producing metacarpal joint flexion, but capable of extending the IP joint because the distal interossei attach directly to the central tendon and the lateral bands. Index and little fingers have weaker IP extension than the middle finger and the little finger. Overall, proximal components are effective. So, most consistent activity of the interossei is when the MCP, metacarpophalangeal joints, are flexed and interphalangeal joints are extended. So, these are the palmar interossei. You can see the palmar interossei, which are very effective adductors, and these are the dorsal interossei, effective abductors. Now we come to the next group of muscles, that are the lumbricals. The lumbrical muscles are the only muscles in the body that attach at both ends of the tendons of other muscles. Each muscle arises from a tendon of the FDP muscle in the palm, then pass volarly to the transverse metacarpal ligament, and then get attached to the lateral bands of the extensor mechanism. On which side? The radial side. The insertion of the lumbrical muscles on the lateral bands of the extensor mechanism distal to the attachment of the distal interossei muscle. This makes them consistently effective interphalangeal extensors, although they are doing action at MP joint also. So, okay. Then there is this deep transverse metacarpal ligament, which also plays an important role towards the lumbrical muscles. Now, what happens? The deep transverse metacarpal ligament prevents the volarly located lumbrical muscles from migrating dorsally and losing tension as the metacarpophalangeal and interphalangeal joint extend. When a lumbrical muscle contracts, it pulls not only the distal attachment but the proximal attachment also. So, it is pulling the lateral band and the FDP tendon. Because the proximal attachment of the lumbrical muscle is on a movable, it is a tendon. Shortening of the lumbrical muscle not only increases tension in the lateral bands, but also it extends the IP joints and also pulls the FDP tendon distally in the palm. This distal migration of the FDP tendon releases much of the passive flexor force of the inactive FDP muscle at the MP and the IP joints. This you can see here. This is the lumbrical muscles. Tension in these lumbricals on the lateral bands produce IP extension, while the lumbrical muscle simultaneously releases antagonistic tension over the FDP tendon. The distal insertion of the introssi muscles can also extend the IP joints. However, they are less effective as IP extensors in the absence of lumbrical muscles, because the introssi muscles do not have the same ability to release the passive resistance of FDP tendon. Okay, when they are doing the IP extension. Now we will discuss about the thumb. Thumb we all know is a very important component of the hand. So we'll be discussing about the first joint, that is the carpometacarpal joint, or the trapeziometacarpal joint between the trapezium and the base of first metacarpal head. You can see it here in the diagram. It is a saddle joint with 2 degrees of freedom, flexion extension, abduction adduction, and permits some axial rotation. Net effect being circumduction, which is also called as opposition. Now, the carpometacarpal joint of the thumb, as we all know, is a saddle-shaped joint. The actions over it is flexion extension and abduction adduction. So, the capsule of first carpometacarpal joint is relatively lax, but it is also reinforced by radial, ulnar, volar, and dorsal ligaments. There is also an intermetacarpal ligament that helps teeth at the base of the first and second metacarpals, preventing extremes of the radial and dorsal displacement of the base of the first metacarpophalangeal joint. The dorsoradial and anterior oblique ligaments are reported to be key stabilizers of the carpometacarpal joint. Any degenerative changes with aging over the carpometacarpal joint may be due to the cartilage thinning or overloading or biomechanical instabilities. The closed pack position is extremes of abduction and adduction. There is a unique range and direction of the motion in the first CMC, which we call at opposition. It is the sequential abduction, flexion, and adduction of the first MC with simultaneously rotation. Now, next are the metacarpophalangeal and interphalangeal joints of the thumb. They are between the head of the first metacarpal and base of the proximal phalanx. These are the condyloid joints with 2 degrees of freedom, the movements being flexion extension and abduction and adduction. There we have the stability factor being provided by the capsule, volar plates, collateral ligaments, same as we have read in the MCP joints of the fingers. Function is also the same, to provide flexion range to the thumb, and also in addition opposition and allow the thumb to grasp. Though structure is same, flexion extension ranges are half of the other fingers. That is very important. And abduction adduction is extremely limited. Then the IP joints, these are present between the head of the proximal phalanx and the base of the distal phalanx. We have only one IP joint over the thumb, and the joint structure and function is similar to those joints and similar to those joints of the hand, other fingers. Now, musculature, we have the extrinsic thumb muscles. We have 4 extrinsic thumb muscles, that is flexor pollicis longus, extensor pollicis longus, extensor pollicis brevis, abductor pollicis longus. The flexor pollicis longus is inserted on the distal phalanx. It correlates to flexor digitorum profundus. At wrist, it is invested by radial bursa, as we have seen in the long digital muscles. And the uniqueness of this tendon is that its function is independent, only muscle responsible for the thumb flexion at IP joints. Other 3 muscles are extensor pollicis brevis and abductor pollicis longus. They have a common course and they go to dorsal forearm and then to first dorsal compartment and radial aspect of the wrist. We will read in some diseases like de Querion's disease the importance of these 2 tendons, and these being in a common course. The abductor pollicis longus, another tendon, inserts on the base of the metacarpophalangeal joint. extensor pollicis brevis inserts on the base of the proximal phalanx. Extensor pollicis brevis helps in extension of the metacarpophalangeal joint. Extensor pollicis longus inserts on the base of the distal phalanx. Extensor pollicis longus is joined by the expansion of abductor pollicis longus, as I told you earlier, and are working as a one unit. Then there are intrinsic thumb muscles. We have the 5 thenar muscles which originate from carpal bones and the flexor retinaculum. These are the opponent's pollicis, only intrinsic muscle having distal attachment, which has an attachment on the first metacarpal on the lateral side. It is a very effective muscle in the positioning the metacarpals in the abducted, flexed, and rotated posture. Then we have other 3 muscles like abductor pollicis brevis, flexor pollicis brevis, and adductor pollicis. We also have one more muscle which works along with them. That is the first volar introsite, which is inserted on the proximal phalanx. Then we have one more muscle, that is flexor pollicis brevis, which has 2 heads of insertion. Large lateral head attaches to the abductor, to the ABL, and the medial head attaches to the adductor pollicis. The first dorsal introsite were not considered as a thenar muscle because it is considered in the dorsal introsite. As it is attached to the thumb, we consider its action and its contribution to the thumb function in carpometacarpal joint distraction, and it also assists in thumb adduction. Then we have thenar muscles which are active in most grasping activities. The activities of these extrinsic thumb muscles in grasp is mainly their function which lets them to help to position the MCP joint and IP joints in a position that they can perform proper grasping. So now at last I would like to discuss the functional position of the wrist and hand. The functional position of the wrist and hand is when the wrist is in slight extension, 20 degrees of extension, slight ulnar deviation, that is 10 degrees of ulnar deviation. Fingers are moderately flexed at MCP joint, around 45 degrees of flexion, and proximal interphalangeal joints also at 30 degrees of flexion. There is slight flexion at the distal IP joints. Functional position of wrist and hand is very important in performing almost all the activities of the hand. With this, we conclude the biomechanics of hand. If anyone has any query, you could WhatsApp me, you can email me, or you can call me. I hope this was fruitful and knowledgeable for you all. Thank you, and see you all in the next lecture.